Welcome to This Week in Emergency Medicine. This week we're covering 7 notable papers, spanning post-cardiac arrest critical care, risk stratification and decision rules in trauma, and equity and quality in acute pain and toxicology care. Let's dive in. We start with 2 large trials that both ask whether more intensive post-arrest intervention actually helps, and both answer no. In the New England Journal of Medicine, the logical trial randomized 1,840 unresponsive, mechanically ventilated adults across 53 intensive care units in Australia, New Zealand, and Ireland to conservative or liberal oxygen therapy after resuscitation. Both arms shared a lower saturation limit of 90%. The conservative arm capped the upper alarm at 95% and weaned inspired oxygen down to room air where tolerated, while the liberal arm had no upper limit and a minimum inspired oxygen fraction of 0.3. At 180 days, survival with a favorable functional outcome on the extended Glasgow outcome scale was 38.2% with conservative oxygen versus 39.7% with liberal oxygen, a relative risk of 0.97, with confidence intervals crossing 1 and a p-value of 0.65. This was a flatly neutral result, not a signal of benefit, and no adverse events were reported in either arm. The practical reading is that within these fairly generous boundaries, obsessive oxygen titration in the first hours after arrest is not what determines outcome, though avoiding frank hyperoxia remains sensible physiology. Alongside it, JAMA published ICECAP, an adaptive allocation trial across 71 United States hospitals that randomized 1,158 comatose out-of-hospital arrest survivors, already cooled below 34 degrees within 4 hours, to hypothermia durations ranging from 6 to 72 hours. Using a Bayesian duration response model with a weighted modified Rankine scale at 90 days, the trial stopped early at interim analysis. In the non-shockable cohort, which made up the large majority at 883 patients, the posterior probability that 6 hours, the shortest duration tested, was optimal, was 0.51, and the shockable cohort looked similar. There were no differences in secondary outcomes or mortality across durations. Read together with logical, the message for the emergency clinician is consistent. Prolonging or intensifying these particular interventions does not buy neurological recovery, and our attention is better spent on high-quality resuscitation, early coronary evaluation, and avoiding fever and secondary insults. Turning to risk stratification, PLOS Medicine reports a prospective multi-center cohort of 1,620 European patients aged 65 and older who presented to 5 emergency departments with mild traumatic brain injury after a ground-level fall and underwent computed tomography. Mean age was nearly 85. Significant acute traumatic intracranial hemorrhage occurred in 72 patients, about 4.4%, and only 5 patients, 3 in 1,000, needed urgent neurosurgery. 8 predictors emerged as both strongly associated and reliably assessed. A visible forehead or scalp impact. A Glasgow coma scale below the patient's baseline. Focal neurological deficit. Signs of basal skull fracture. Acute confusion, vomiting, loss of consciousness, and headache. 2 derived rules, PI1 and PIW2, each achieved 100% sensitivity, with specificities between roughly 25 and 44%, which would have avoided between 25% and 42% of head CTs. The caveats matter. Only scanned patients were enrolled, raising selection bias. There was no centralized imaging review, and this is internal validation only, so do not stop scanning anticoagulated octogenarians on the strength of this paper. But the visible impact location is a variable most of us do not systematically record, and it deserves attention. Pre-hospital emergency care takes a different approach to prediction. Using more than 2 million 911 emergency medical services activations for motor vehicle crashes in the National Emergency Medical Services Information System, to model who receives pre-hospital blood transfusion. Random forest and ridge penalized regression models discriminated well, with areas under the curve of about 0.90, driven by composite physiologic measures and shock designations, and projected that roughly 2 to 4% of crash patients nationally would be high-probability transfusion candidates. This is a systems planning tool for deciding where blood products should live, not a bedside triage rule. Our final theme is the quality and equity of acute symptom management. In the American Journal of Emergency Medicine, a systematic review and meta-analysis of 6 studies and 3,367 children with sickle cell vaso-occlusive episodes found no significant difference between early and delayed opioid administration for hospital admission, emergency department discharge, length of stay, or pain reassessment, including in a subgroup analysis split at 60 minutes. The authors note individual studies suggested benefit from timely repeat dosing and intranasal fentanyl, so the fair interpretation is not that speed is irrelevant, but that a single early dose without a structured redosing pathway may not change disposition. From the same journal, a 10-year retrospective analysis of 12,650 children undergoing facial laceration repair in 2 pediatric emergency departments found that non-Hispanic white children had modestly but significantly higher adjusted odds of receiving anxiolysis or sedation, about 17% higher than the grand mean, while preferred language showed no significant association. That is a discretionary, comfort-related decision showing a racial gradient, and it argues for protocolized default anxiolysis rather than case-by-case judgment. Rounding out the journal, a scoping review of carbon monoxide-induced myocardial injury reports that 20 to 40% of patients with moderate to severe poisoning show biomarker or electrocardiographic evidence of myocardial injury, associated with a roughly 2-fold increase in long-term mortality and adverse cardiovascular events, often in young patients without known coronary disease. The authors argue for routine electrocardiography, troponin, and bedside echocardiography in significant exposures. If you only have time for one paper this week, make it the JAMA ICECAP trial. It resolves a question that has driven post-arrest protocols for 2 decades. And the answer, that longer cooling adds nothing, will reshape targeted temperature management pathways that emergency physicians initiate. Here are the key takeaways from this week in emergency medicine. First, neither conservative oxygen targeting nor prolonged hypothermia improved functional outcomes after cardiac arrest. Both trials were neutral, so focus on the fundamentals rather than protocol intensification. Second, in older adults after a ground-level fall, history and examination findings, including visible forehead impact, may safely reduce head CT use. But these rules need external validation before you change your scanning threshold. Third, in pediatric sickle cell crisis, simply giving the first opioid faster did not change admission or length of stay. Build pathways around repeat dosing and intranasal routes. Fourth, sedation and anxiolysis for laceration repair varied by race and ethnicity, which is a strong argument for standardized protocols. And fifth, consider an electrocardiogram and troponin in anyone with significant carbon monoxide exposure, because cardiac injury is common and frequently silent. That's your roundup for this week in emergency medicine. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.